So, great, got it. Welcome, everyone. I may be having some trouble with my video today, but I think the audio is okay. So hopefully, if you can't hear me, type something in chat or just unmute and let us know. So thank you so much for joining us for today's webinar, which is working with individuals actively using alcohol and/or drugs. Knowledge, strategies, and dialogues with our co-presenters today are Jennifer Neifeld and Jacqueline Foster of 820 River Street Incorporated. So this is the second webinar offered by the North Country Care Coordination Workforce Collaborative, or NCWC for short. My name is Joanne Evans. I'm the director of the Health Resources and Services Administration Rural Public Health Workforce Training Network grant out of Adirondack Health Institute, through which the NCWC was established. The NCWC is a regional consortium of employers, providers, educational institutions, and workforce stakeholders focused on rural healthcare workforce needs within 8 counties in northeastern New York State. It's also meant to foster a sustainable and inclusive career pathway for care managers and case managers. Today, I'm joined by Kelly Owens, who is the executive director of the Hudson Mohawk Area Health Education Center. Kelly and AHEC assist the NCWC with program development, planning, and technical support. So she and I will work together today to try to ensure that everything runs smoothly. We do have a few housekeeping items. This webinar is being recorded and it will be posted on the Health Workforce Collaborative website under the Care Coordination section. So we'll be putting the URL in chat later. We do ask that you remain on mute for the duration of the training. Cameras are optional. There will be time at the end of the presentation portion for Q&A. So we encourage you to enter any questions that you may have into the chat box, and then we'll review them towards the end of the program. We do have a brief program evaluation that we will email to all participants. We'll also put the link to the evaluation in the chat at the end of the program. We do ask that you take time to complete the evaluation. It takes about 2 minutes. Your input and feedback really is important to us, and it helps us to determine what programming to offer next. This webinar has been approved for 1 continuing education credit hour for social work, licensed mental health counselors, physical therapy, and occupational therapy. We also have certificates of completion available. So if you'd like a CE hours or a certificate of completion, please make sure to stay on the training for the full hour. We will be taking attendance, as the regulatory bodies that approve the CE credits require full participation. Participants will receive certificates by email after the evaluations have been submitted and reviewed. And just to mention, this presentation is supported by the HRSA grant, as you can see the disclaimer there. So now, without further delay, I just want to turn it over to Jennifer Neifeld and Jacqueline Foster, and we really hope you enjoy the program. Thank you.
Thank you, Joanne. Good morning, everyone. I'm Jennifer Neifeld. I am the CEO of 820 River Street and Peter Young Housing Industry and Treatment. I've been with 820 for 16 years now and worked in all various positions throughout this organization. And when Joanne and I began this conversation regarding this webinar, I was so excited to be able to present this. We live in a very rural area also, and we understand the many challenges that we face. Jackie is going to roll us through this webinar, and she will be touching on many of the different topics, drug classifications, motivational interviewing, how to have dialogues with your clients. I will probably refer to the population as clients, but we also understand that some of you may use individual patients, but for us, we've always reverted to the clients when identifying our population. So I will turn this over to Jackie Foster, and she will introduce herself and move on.
Good morning, everyone. My name is Jackie Foster. I too have worked with Jennifer for quite a while at 820 River Street. also known as the Baywood Center in our area. So if you see any resource guides or anything that say the Baywood Center, that is also us. And then any housing that is under Peter Young Housing Industries and Treatment is also us. I've been with the agency since 2008, working with people with addictions, and helping identify programming and doing counseling and case management and care management and all that kind of stuff that kind of rolls into treating a person with substance abuse disorder. So when Jennifer was asked by Joanne to do this training, she roped me into it as well. So I'm happy to be here with you guys today. Like Jennifer said, our goal for today is to kind of identify how to work with a difficult population, and to understand addiction a little bit better. There's a lot of words on my slides. It's not because I plan on reading them directly to you, but I feel that the presentation is something that you can hold on to for the future or share with other people who might not be able to be here today. So like Joanne said, if you have any questions, please feel free to put them in the chat box, and Jennifer and I are happy to answer them at the end. So the first thing we kind of wanted to talk about today was that when we look at substance abuse, we look at it on a continuum. And the reality is that different people use different substances in different ways. And when we're working with them as far as addiction services go, we're normally dealing with them once they have entered into an area where the substances begin to cause problems in their lives. But we also understand that people can use substances and it doesn't really cause a lot of issues. And or the person may have used a substance for a period of time without any issues, and then now all of a sudden it's starting to cause issues. So the really important thing when you're looking at addiction is to realize that what we call is it's a continuum. People can slide back and forward on that continuum. People can, minimize risk and consequence for a while on the continuum. So just because a person is using a substance doesn't always mean that we believe that they have a problem with that substance or that they're addicted to that substance. If you look at the definition of addiction, it certainly talks about the idea that there has to be negative consequence and continued use and tolerance and physical reactions to that substance to become an addiction. So the mere just using a substance is not enough to give someone a diagnosis for substance use disorder. So we're really looking at it becoming more of this idea where it reaches this problematic to potentially harmful area before we start being able to identify it as a substance use disorder. However, that doesn't mean that people working with others don't start to see it as a problem prior to the person experiencing consequences. Or we've worked with people in the past knowing that it's going to become an issue, and trying to kind of identify how to help that person have it not become a bigger issue is also something that can be done to help people before it becomes a problem. When I enter, Jennifer and I talked about entering the field 15 to 20 years ago. And when we entered the field, we really entered in a time that it was very abstinence based. I entered as a counselor in the field, and when I was working with people, it had to be, their treatment plans had to be based on getting them to stop using. All of our goals were oriented towards no use, stopping using, not relapsing, things like that. However, over the last 15 to 20 years, there's been a major shift in our field to a more, harm reduction or person-centered approach. Person-centered approach is really the term that's coined and used a lot nowadays. But the idea with person-centered approach is understanding that not everybody is going to be, one, willing to enter into the level of treatment that is appropriate for them, or two, not everyone responds to levels of treatment in the same way. So I think as you are working with the people that you're working with, it's important to understand that as professionals, we oftentimes know probably the appropriate level of care or what kind of intervention somebody needs. but that person may not be willing to do that level of care, or they may have barriers that impact their ability to do that level of care. So there's really been a shift in the field to talk about, okay, well, what can we do to reduce harm to that person? How can we limit those consequences that we talked about on the last slide? And when working with people with medical conditions, how can we, limit the impact that the substance use is potentially having on their ability to take medications, their ability to remember to go to appointments and things like that. So some of the strategies that you utilize with those people may not necessarily be specifically about stopping use, but more about reducing the consequences associated with the use. Jen, did you want to add anything in?
I was just gonna, add, for me, the abstinence model was the only way to go. And I'm kind of like a dinosaur in the field. I had a lot of, pushback, and I had a hard time accepting this. But this is where we are now. And also it's opened up a lot of doors. The harm reduction model, the medicated assisted treatment, the peer engagement. These are all levels of care that just never existed. And it's proven to be such a success to have these different options and to meet the people where they're at with these. I think the success is far greater than just saying stop using, just stop. So go ahead, Jackie.
So I wanted to make sure that everybody was aware of the different levels of care that we have available in our system. So the first one being detox on here. So detox really is looking at clients who would have a major medical issue if they were to stop using. Primarily that's really with alcohol, benzodiazepines, and sometimes opiates. You're really not going to get somebody admitted to a detox for cocaine, definitely not marijuana, or hallucinogens, things like that. So you're really looking at a medication that's going to cause a physical reaction when the person stops using it. And oftentimes people won't stop using because they don't want to go through detox. It's a very uncomfortable situation and feeling. So if we can encourage them to go to a hospital-based detox program, we can let them know that it's going to help you do it in the most comfortable way possible, with medications that are going to help you feel the most limited impacts of stopping the drug. And also reminding them and educating them that coming off of some substances can be deadly for them. And that's the reason, the real reason for detoxes being in hospitals, because there can be a lot of physical medical issues when someone stops using some of these drugs. So like I said, a detox is usually normally always in a hospital. It's run by 24-hour medical staff, and it's usually about 3 days in duration for someone to fully detox off of a substance. Many people will detox in their own homes. And I do know of some primary care doctors that will help prescribe certain medications to somebody trying to detox on their own. Detox can be I'm just going to stop taking this drug right now and I'm not going to touch it again. Or some doctors will recommend a more of a weaning pattern to coming off of the drug to limit some of that harsh, abrupt side effect of coming off of the drug. So that's detox. Outpatient level of care is probably one of your most common levels of care in community. So for that, what it means is the person goes to treatment, usually with a substance abuse counselor. There's oftentimes other medical staff there, but the programs are usually open during the day and night. They're not open 24 hours a day. People don't live there. People don't stay there. Most clients come in for 1 to 3 hours a day, or even less frequent than that. Some people might only come once a week. So it's really based on what the client needs and individualized treatment plans. So I would say that's probably the most common treatment available in your community. The other one here, I put peer engagement. So this is really a new movement in addiction services nowadays. So peer engagement is working with what we call certified peer recovery advocates, and they are people who have addiction histories themselves, who work with other people who are in, trying to either get into recovery or currently using substances, and they help them identify barriers, break down barriers. They talk about the process of recovery. They relate to them, across the continuum of their own addictions. They share their histories and past, and a lot of hope. There's that idea that recovery is possible. It does suck getting there sometimes, but it is possible, and I'm here to help you do that. They help with housing, they help with referrals, they help with connections to inpatient care. They connect with aftercare plans. So it's a lot of services available in that, kind of one category of treatment. Inpatient is another widely known level of care. Inpatients are usually either run out of a hospital or a non-hospital based program. I do want to put out there that hospital-based programs are really the type of programs you're going to want to look to if your client has a medical condition. A lot of the standalone inpatients will not accept people that have more problematic medical conditions, heart conditions, some levels of pregnancy sometimes can be an issue. So if you're or mental health is another one that can kind of preclude someone from going to a standalone inpatient program. So if your client has a lot of medical concerns, I would really urge that you're looking for a program that's in a hospital, because they're more likely to accept them. Also, the other thing with inpatients is to recognize whether the program is a state-run program through OASIS or if it's a private-run program. And that's going to help with things like insurance, really, because your state-run programs are going to work with people on their insurances and take people who are even uninsured. So if you have a person who hasn't gotten their insurance yet, that's a really good, valuable resource to know. Moving on to residential. So residential is a housing level of care within a community. So normally people live there for an extended period of time. So you're looking at 3 to 6 months normally. And there's different levels of that residential care. Some of it is literally where they don't leave that residence at all. All their treatment happens on site. All their services happen on site. All the way down to a very low level of reintegration that we call it, where the person kind of lives there, but they come and go as they need to. They are really using that as a starting block to living independently in the community. So as long as you're aware of what kind of residential program it is, and letting the client know, usually those programs can be very helpful. Education and prevention efforts I threw on here too, because sometimes you're not going to get a person into any of these levels of care. They're not going to go. They're not willing at that point. So that's where we really have to try to utilize educating them on the resources, educating them on what's going to happen if they continue to use, trying to pull in some recovery supports to help them as well. So, it's sometimes the only intervention that we have with people when they won't go to some of these more institutionalized services. So, and then prevention efforts also, that's a large area to cover. But what you're looking at with the prevention efforts is not only the services that happen in communities, but also in the school systems with adolescents that are happening at community events. It's campaigns on TV. So, while they're not usually working with one specific person, they're working with a large majority of people. So, prevention is a level of care and an intervention that can be helpful to people. Just a couple things to remember on here. I think I kind of mentioned it once or twice, but match up the person to what they're willing to go to. And why I say that is because we've connected people to the lowest levels of care before, only to find that they will eventually work their way up that ladder into the level of care that they actually need. But at that moment, they're just not willing to engage in that higher level of care at that moment. And really identifying that it's not about you telling them what to do and what they need, but them kind of accepting and working with you as a partner into what they need. It goes a lot farther if you can work with them as a partner, than trying to tell them what they need. So, and really, you know, trying to limit confrontation. It's hard sometimes when we can see all the devastation and the consequences going on around them to, you know, not try to instill that in them and kind of utilize some of those as motivating factors. But what we found in treatment is that that really becomes shameful to them, and they pull back and they withdraw even more, versus wanting to be, you know, in treatment to negate those consequences. And then really to be aware of all the barriers that are in someone's way to getting into treatment. You know, this webinar is not about our programming, but one of the programming aspects that we had to develop was a program that goes out into the community to help reduce people's barriers to care, because we knew that they weren't going to ever come into treatment if they didn't get transportation or didn't get somewhere to live or didn't have someone to watch their children. So sometimes that's where you have to start first before you can even start with treating the substance abuse side of it. All right, so these next couple slides I'm going to kind of fly through, only because, you know, this is more for you to keep the slides than for me to really go through them. But when we talk about drug classifications, really we're talking about 3 different classifications. The first being depressants. Those are drugs that are going to slow down the nervous system, the breathing system, heart rates, things like that. It's alcohol, benzos, opiates, sleep medications, muscle relaxants, marijuana. And as most of you can probably conclude, you're going to see symptoms, physical symptoms within the person of their body kind of shutting down. So slower speech, slurred speech, slow reaction time, memory issues, them losing time, sleepiness. And then as far as the pupils go, because the pupils can be a good indicator as to what type of substance a person is on, you're looking at small pupils and bloodshot eyes. In this section too, in really big letters, I put that drugs impact people differently. Working in the field, that's one of the biggest things I've recognized, is that you can never always tell what a person is using just based on the symptoms, because different drugs will impact people differently. So most commonly, this is what depressants will look like with someone, but I've seen it look very different as well. Stimulants are the opposite of depressants. They will increase your heart rate, they increase your breathing rates, your nervous system. Those are things like crack cocaine, amphetamines, methamphetamine, ecstasies, and caffeine. And you know, as far as physical symptoms, you're looking at irregular fast heart rates. This is where you're, you know, commonly seeing things like cardiac arrest if someone's using high levels of those substances. But you're also looking at a lot of weight loss, fidgetiness, increased anxiety, and, you know, and then going back to kind of that eye being the indicator, you're looking at the opposite, which is large pupils. And you can also sometimes see some aggressive behaviors that come out in people using stimulants. And then on the other side of the slide, probably a little bit less commonly used is hallucinogens. And those are substances that distort reality for somebody. So mushrooms, LSD, PCP, ketamine, I don't know why caffeine is there. I'm sorry. Caffeine's not one of them. But the major thing that you're looking at, you know, and a sign that someone's utilizing something like that is someone who is normally, you know, kind of in reality or there with you, who now all of a sudden is becoming very paranoid, or you know, is talking about things being in the room, experiences that didn't happen. things like that are going to be the main symptoms that somebody may be using types of hallucinogens.
Jackie, can I just interject for a minute?
Sure.
I just wanted to bring to mind that we hear a lot about the fentanyl now in our communities. And we'll see that in the opioids, but we're also seeing a lot of it in cocaine use now. So, you know, we hear so much about it in the overdoses, and it is in our communities. And the level of overdosing is probably extremely high with people that are using fentanyl or may not even know that fentanyl has been laced into their drugs, which is, you know, very common right now.
Yeah, absolutely. So when we're looking at the physical symptoms of someone using substances, it's important to recognize that those symptoms are also not only caused by substances, but can be caused by other physical ailments. It can be caused by stress, lack of sleep, different things like that. So just those symptoms alone usually aren't enough to conclude that somebody is definitely using substances. So I just threw in here as well that a lot of times a person's environment or behaviors also really will help you connect those dots that somebody's using a substance. And not all people are going to be honest about what they're using. So if you're in homes, I definitely encourage you to look around, familiarize yourself with what drug paraphernalia may look like, different smoking devices, you know, definitely if they have needles around, or, you know, any sort of residue, like, you know, different things that have residue on them, look like they've been smoked out of. Those are oftentimes things that people will use to use the drugs. So being familiar with those, looking for a buildup of bottles or cans, oftentimes that's one of the big signs that, you know, somebody is overusing alcohol or liquor. Working with people with medications, another common thing that can happen is medication count errors. So if somebody is severely off on their medications, oftentimes that could be because they're abusing it, or because they're not taking it because they are using a substance instead of taking the medication that they're supposed to. I put doctor shopping on here for anyone who's not familiar with that. It's kind of a term that's utilized to identify people that will go to multiple doctors to get a type of medication that they're looking for. And in that they may be, you know, repeating symptoms that may not be visible. You know, primarily things like pain or anxiety, something a doctor can't say, yes, that's definitely there or not. And when one doctor doesn't give them what they want, they'll go to another doctor. Chronic canceling of appointments is another sign that there's something going on there. Pulling away from people who are supportive. You may have family members telling you that something's not right or that they're using. And then unexplained symptoms of illness. So somebody who appears physically fine, you know, meaning no medical reason why they might be experiencing some of those physical ailments, but they are. And then unexplained financial issues is another big one that we look for, you know, with kind of connecting those dots to say that there probably is an addiction issue going on here. So when it kind of all comes together, we're able to paint a better picture of someone and what they're using, but recognizing that it's not always going to look like this as well. Then the last slide I have here, kind of relating to substances specifically, is that in our field, one of the biggest things that we try to avoid and work on is overdose. And one of the biggest reasons that people are overdosing is because they're mixing substances together. Jennifer mentioned fentanyl before. That's one of the big ones, that's either knowingly or unknowingly being mixed into certain substances. But there's times when people will do it on purpose. to get a certain effect. And then there's also times when people don't know that those substances are in what they're using, or they don't even know what they're using sometimes. I wanted to point out that with overdose and mixing substances, that it's most commonly experimental users that we see that come in, where they were just, starting out using, or they didn't know what they were using, or friends gave it to them, that kind of stuff. So it's a very high level of your beginning users that were experiencing this polysubstance use, where they don't know that they're mixing substances. And then, this bottom kind of bullet here is that what we find is that alcohol is the most commonly mixed drug. So oftentimes people don't look at alcohol as a problem. They don't look at it as a drug. So they're commonly taking prescription medications, drinking alcohol, or they're, taking illegal drugs as well, and then using alcohol too. And this is where we kind of find some of those more impactful medical issues that come from mixing the drugs. There's oftentimes, a saying that, we'll tell people or try to educate people on, is that, 1 + 1 doesn't always equal 2 when you're mixing drugs together, because the way that they interact, it kind of is an explosion within the body, and you're getting a very, exponential type of response inside the body. So they may not even understand that the type of reaction they're going to get in their body, it can have some pretty serious medical issues associated with that. All right. So kind of moving on to what to do, how to help people, and kind of, being able to recognize where somebody is. So there's this idea of the stages of change, and the different stages are kind of listed here. Pre-contemplation being that somebody, has no desire to change at this point. Contemplating meaning that they're considering it, but they're not really fully, into it yet. Preparation, they might start making the goals, or making calls, things like that, to make a change. Action being actually following through with those steps. And then maintenance being that they've, made the change and they're doing what they need to do to, keep that change lasting. However, here we recognize too that these stages are interchangeable. Sometimes they go back and forth. People, will relapse back to a stage previous, or a couple stages previous. So as professionals working with people, it's important, one, to be able to recognize what stage they're in, because different types of interventions are going to be best in that certain stage. And then also recognizing that, the different people will be in different stages at different times. So not all the people that you work with are going to be in preparation action, or someone that you met who might be in, a preparation stage might, revert back to pre-contemplation, and then you got to kind of start over with them and working with them again. So when you're looking at this too, the one thing I would suggest is think about making changes yourself. For me, it's always kind of helped me empathize with the client or patient, because sometimes making changes is not easy. And while we might not be dealing with substance abuse necessarily, just changes like eating healthy, or losing weight, or stopping smoking, those are all kind of things that, if we can relate back to them and understand, it helps kind of have some empathy working with those patients. So
Jackie, can you go back to that slide again?
Sure.
I just wanted to say, under the maintenance side, we have to remember that harm reduction model here, because for some people, maintenance may mean maybe 2 beers a night, and not total abstinence. And, we throw the word recovery around. You're in recovery now. And recovery now means such a different thing to everybody. Me being in recovery is not using. Somebody else's, I'm taking, 1 hit of marijuana a night or whatever. So maintenance can look totally different for different people. And, you know, I just wanted to point out to bear in mind that harm reduction model when you're looking at the stages of change.
Thanks, Jen. So kind of the last portion of our presentation today talks about motivational interviewing. And when I was talking about different types of stages and the types of interventions that can work well in those stages, motivational interviewing is one that can be kind of tailored to work with people at those very early stages of the stages of change. Because you're really, you know, as Jennifer was mentioning, that idea of accepting the person where they're at and trying to move them forward. Somebody once said to me, and I think it was really impactful to me, is that, you know, harm reduction in motivational interviewing isn't about leaving the person where they're at just because they want to stay there. It's more about helping them move forward, you know, while accepting that where they're at. So I think a lot of people, when you hear motivational interviewing or you hear harm reduction, you think, well, you know, the person doesn't want to change, so I just need to accept that and move on. And that's not exactly, you know, the whole idea here. But the idea is, you know, for a definition, a collaborative communication style for strengthening a person's own motivation and commitment to change. So it kind of goes back to that idea of not telling somebody what they need to do, but being a partner with them. And motivational interviewing is something that people can do with, you know, very little training. It's not something that requires somebody to go and get a certification for it. It's really just some changes in the way that you word phrase things for people, how you respond to people. So on this next slide, there's an acronym called RULE. And I think if people can kind of utilize this or put it up in their office when they're working with people, have it on a binder, you know, whatever, you know, this will help you reframe how you're talking to people, and kind of using the motivational interviewing. So the first one being R, which is, you know, resisting telling them what to do. We've kind of covered that in depth today. But that's one of the most important pieces of motivational interviewing is, you know, kind of taking away that I'm the professional and you need to do what I've said, and kind of that idea of, okay, how can we make this work and what do we need to do? And, you know, kind of utilizing those types of phrases versus, well, you need to, you being understand their motives. So one of the big things with motivational interviewing is sitting with the person and understanding why they want to change or why they don't want to change. And then trying to help them identify, like, if it's a reason why they don't want to change, okay, well, why not? And what's going to happen if you continue to not change that behavior or that action? And trying to kind of help them get to the point where they're understanding the consequences, and really trying to use non-judgmental type phrases with them, and trying to help identify and deal with what they think is the primary issue there, versus what you may think is the primary issue. L being listen with empathy. So sometimes it's just sitting there and letting the person talk and tell you about things, versus you trying to fill that space with advice and telling them what to do. And then lastly, kind of coupling with that is empowering them. So giving them the tools to get to the appointments, giving them the tools to make the phone call, you know, whatever it might be to help reach that goal. You're kind of, you know, that cheerleader or the person who's connecting them to the resources that'll help them get there. Another acronym that we use a lot in motivational interviewing is OARS. And these are some more specific techniques you can use. O being open-ended questions. So very basically, that's just questions that you can't answer with a yes or a no. So you're looking to kind of help them open up a little bit more, talk a little bit more. So if you're asking questions that require more than yes or no, then you'll get that with them. A being for affirmation. So it's, you know, recognizing what they've already done well. It's recognizing what they are doing well. It's, you know, pointing out positives to them, or it's helping them develop their own affirmations for the day. I can do this. You're worth this, things like that. Versus some of that negative, kind of self-talk that a lot of people with addiction have. R is reflective listening. So the easiest thing to think about with reflective listening is kind of repeating back to the person what they've said to you. One, that shows you're listening, and two, it clarifies that yes, that's actually what the person meant and wants, versus the way that we sometimes hear it, thinking about it in a different light or different context. And then S is meant for summarizing. So after you're meeting with a person, kind of summarizing, okay, what is the goal? What are we going to do? What do you want? And kind of going back to that summarizing throughout your next sessions as well, to kind of summarize, okay, well, last time I met with you, you said, and helping kind of remind them that they did share with you that they want this or that they want to change. And kind of keeping them in direct. And then the last technique I have here for today for motivational interviewing has to do with a technique we call change talk. So that's getting, very simply, it's getting a person to change their internal thought process into a different type of thought process, usually more in a more positive direction, or a more change-oriented direction. I gave a couple examples here of what we call sustained talk. And usually what that is a client telling you why they can't change or why it won't work. That's kind of that very negative self-talk. So I threw an example in here of, I can't stop smoking cigarettes because I will be too stressed out. Something we commonly hear when we talk to people about stopping using cigarettes. So by kind of working with them and identifying what might be some of the consequences or some of the barriers to quitting smoking with them, not just accepting that, okay, well, you don't want to quit smoking because you'll be too stressed out. If you can get them to kind of change their thought process to something like, I'm spending a lot of money on cigarettes. Maybe if I stopped smoking, I wouldn't spend as much money. Or, could you help me learn other ways to deal with stress because I don't want to spend all that money on cigarettes? So you're kind of changing what the reference is and what, getting them to think about it in a different manner. I deserve a beer after a hard day's work. Okay, well, what does that beer lead to? And how do you feel after you actually drink that beer? Do you ever, does it just stay one beer? And then, this last one on here, kind of being more of a level of care type of a thing. I don't need a community residence. I can stay sober on my own. And kind of challenging that a little bit with them, and getting them to move to a point where they say, what, maybe that is a safe place for me to stay. So utilizing education, educating them on what a program looks like, what they can expect, and then kind of challenging a little bit of that too. What does it look like to stay sober on your own? Have you been able to do that? So you're utilizing, stuff like that, versus telling them, well, I filled out this piece of paper and this piece of paper says you need to go to this level of care, which is kind of what our process is. But they don't need to know that. So the last couple slides just kind of hit on a little bit more of the techniques and interventions that we talked about. And I broke it down between a couple different scenarios, one being people that have no desire to quit, another being people who are using prescription medications, and then people who do want to quit but who have quit but relapsed. So those, kind of looking at maybe the different types of clientele that you guys are working with. So starting with someone who has no desire to quit, being in that what we call pre-contemplative stage. Some helpful kind of dialogues to have with them would be sitting down with them and asking them to look at, what does it look like if you did stop? What does that future look like for you? Understanding the benefits for them. Like I said before, trying to limit judgment, not using the shoulds, and changing it to what would it look like if, So that's coming more from them versus coming from you. Utilizing education techniques with them, helping them understand if you continue to use this, this is likely what's going to happen. Same with kind of that impacts of continued use. And then as Jennifer mentioned before, really starting very low with them and talking about, okay, well, if you're not willing to stop, what does cutting back look like for you? Maybe you start later in the day, maybe you buy less. So you're trying to help them just kind of limit how much of the intake they're having throughout the day.
Jackie, can we just stop for a minute?
Mm-hmm.
What comes to mind also is you may have a client who has tried to stop in the past and, you know, continues to make the attempts to try to stop, and they're feeling like, yeah, this is never going to work for me. And at that point, you know, one of the questions I always ask is, what is it that we're missing, and what is it that you feel you need? And maybe at that point, a conversation about medicated assisted treatment has to happen. Some people aren't aware of it and the benefits of it. Some people, you know, are feeling like, I just can't make this happen. I can't cut back. I don't know what to do. And I think that, you know, really talking about the options and what it looks like can help move them forward and give them a little hope that they can do this.
Yeah, absolutely. And kind of going back to that slide of, you know, there's multiple levels of care. And whatever you can get them to kind of buy into is where you should start. All right, so our next person here would be an individual who is using prescription medications or have a medical condition that use alcohol and other drugs. So this doesn't really necessarily touch upon where the client is at on that stage of change model, but some interventions to utilize is to educate them on the health risks. So bringing pamphlets, talking, you know, having them talk to somebody else who maybe has some of those health issues associated with mixing the substances with the medical prescriptions or the medical conditions, having their doctor talk to them, you know, support groups, things like that, discuss harm reduction as a possibility, discuss spacing out medications. So in drug use, so if you take your medication in the morning, can you wait till noon to start drinking? You know, so just having kind of conversations with them about that. And then educating them on the signs to look for with the interaction. So if we know that there's an interaction between the substance and the drug medication, then if we can try to educate them on that, then they might recognize it. And you know, especially highlighting any of the more harmful or deadly types of interactions that could happen.
So that's the end of our presentation, and we are open to any comments, questions, anything that you think might be helpful that we can give you some information on. I believe they're going to put our contact information on these slides. You'll have availability. Jackie and I welcome conversations to have with you away from this webinar anytime. We're always available. Are there questions?
Yeah, please feel free to post any questions in the chat box, or if you'd like to unmute yourself to ask the question, feel free.
I hope this webinar has been helpful. I know we've had a couple of different conversations you know, about some of the barriers that you experience on a day-to-day basis. And although we gave you some information, there's, you know, a lot of different techniques, you know, that we could possibly help you with, and, you know, getting referrals to the right services. I believe we've had a conversation about that can be very frustrating. So if there's any other areas that we can help you with, please reach out to us. We'd be more than happy to help provide some more information.
Yeah, absolutely. And I was trying to kind of rush along earlier because I knew we had a time constraint. But one of the things that I really stress in some of the work that I've done is making connections to the services that you utilize, going and visiting them, meeting the people in the program, so that when you do have somebody who is ready to get into treatment, at whatever level of care, you can make a call to that person and get that person in quickly. I know sometimes wait times are something that we struggle with and deal with. But I found through some of the personal connections that I've developed in the community, I can get people in a lot faster. And also utilizing some of the other programs that might have, not sure exactly what their names are, but they're kind of coordinators for the services. So I know with a couple inpatients, we can call directly to a specific person. And that person handles everything, and we can usually get them in with a day or two. It might mean taking the person out of the area, meaning that, you know, we're not going to be able to use the inpatient that's an hour away or, you know, 20 minutes down the road. We might have to send them a little bit further. But these programs specifically have coordinators in our area to help facilitate that, the transportation, everything. And it's really helped get people in quickly, versus, you know, someone expressing interest in going and then you're waiting a week or two before someone has availability to get them in.
This is Joanne. Jennifer and Jackie, I'm not a care manager or care coordinator, but I guess one question I had is, you know, if a care manager is going to a client's house for, you know, a routine visit, what happens if they, you know, arrive and the client is actively under the influence? How would they, how should they handle that situation?
Well, for me, I think it goes back to the agency's policy on that, you know, because I think, you know, for my example, when we have someone who comes into the clinic who may be impaired, some of our services can still be offered. But sometimes they can't because the person can't consent to things. They can't do certain things when they're under that level of impairment. But one of the suggestions I would offer is, if any of the agencies in your area offer certified peer recovery advocates, oftentimes those are people who can respond more quickly, and can come to the home of the individual, and kind of help them, you know, either sober up or get to a point where they can complete the appointments with the care managers, and kind of help that person understand that, you know, I know this probably doesn't feel good, or I know that you want to get to this outcome with your care manager, but you can't get there until you do this. And they can take kind of a hands-on approach, and they can work with people who are still using.
The other thing I think is kind of trying some of that motivational interviewing, like, you know, saying, you know, I'm going to be there at 11:30 this morning. I know you enjoy having your cocktails in the morning. Do you think that we could just put that off for an hour? Or, you know, kind of get them, you know, to limit their use during the time that you're there. It's got to be frustrating, you know, for some of your care managers. But once again, I think that the client has to buy into a benefit, and not feel like they're being judged, or, you know, giving them this expectation all the time that they're not able to meet. Um, and like Jackie said, if you had a peer Serpa, you know, maybe they can help them. If they know that the care manager is going to be there at 10, they could be over at their house at 9, you know, kind of talking them into the preparation for the appointment. You know, it's a tricky one. It's very tricky.
Another
That's
tool that's
helpful.
been useful too, it doesn't seem like it would be, but we've actually found some success with it, is to have the client come to you. And they usually have to utilize family supports and things like that to do that. And so usually they will at least be sober or less intoxicated if they're coming to you versus you coming to them.
Hi, this is Lori Bishop. I just wanted to throw out, I think sometimes for us as care managers or even human beings, right? I think our big battle that we frequently have is, you know, where is the line of supporting somebody versus enabling somebody? Especially in a care management capacity where you're kind of always on call to assist with food baskets and different things, which at times just kind of feed into, and again, I don't mean to say that in a disrespectful manner, but you know, they just swapped all their food stamps to get some drugs and now they don't have food and you're running to get it. It's like, sometimes it's hard really to know, you know, how is this really being helpful, right? You're trying to maintain their basic needs, but are you really just part of the bigger plan at times, to allow that access of continued use? I don't know. It just, sometimes I know in my work, and I do have several, you know, very active users, I feel like I'm in this rescue mode all the time. And I'm not sure how far I'm overstepping and really undermining their ability to make different choices for themselves where they're at, you know? It's a struggle.
Yeah, and I think, Lori, I think that's definitely real. And I think sometimes when we do these presentations, it's like, yeah, that's great, but what about these real situations that we deal with? And I would say, you know, our counselors deal with the same exact ethical dilemma, I guess you would call it, of, you know, continuing to support the person versus being enabling or allowing the behavior to continue. And I think setting, you know, my thing with them, I used to be their supervisor, was setting boundaries with them, setting limits, letting them know that, you know, if you continue this, I can't help you do this. You know, so it's kind of going back to that idea. It's not just condoning what they're doing, but it's also, you know, putting things in the way to kind of motivate some change as well, or incentivizing them to make changes. So, you know, it sounds like what you're kind of describing is they call and you go. Well, that doesn't always have to be the answer. You might be able to say, well, I'm only going to do it once a month, or, you know, something like that.
It's 12:30, so if you know, it looks like we may have wrapped up the Q&A portion. If anyone has any last minute questions, by all means, go ahead and either unmute or ask them. Otherwise, we'll go ahead and wrap up. Kelly has put the link to the Health Workforce Collaborative website where this recorded presentation will be posted, and also the link to the evaluation. So Jennifer and Jackie, thank you so much for an excellent presentation, and thank you to everyone who was able to attend today. If you have further questions for Jackie and Jennifer, they have provided their email addresses. So do you have any last minute comments or thoughts? Or
I'd just like to say thank you.
You're welcome.
Thank you for having us.
thank you so much for doing this. All right.